Next is my pleasure to introduce a very close colleague of mine. Well, I like to think that all my colleagues are very close. But regarding Dr. Klein, this is not only figuratively, but also literally, as her office door is actually next to mine. So I always bother her for a second opinion in many cases, as we share her, Dr. Dasaraju, and myself, also the breast service. So Dr. Klein is an associate professor in our department, and she's involved in many studies. Probably the most notable I would like to mention are the Oncotype DX studies. That it is a widely used commercial assay for making chemotherapy decisions in ER-positive breast cancers. She also is involved in studies regarding quality assurance issues concerning the Oncotype DX assay, specifically the false negativity associated with assays detection of HER2, which is an important prognostic and predictive marker. So please welcome Dr. Klein. Thank you.
Thank you. Speaking about breast pathology and quality assurance, and I thought I could say a lot of things, and I had to kind of trim it down in this period of time. So I'm going to emphasize diagnoses of breast core biopsies, which many of you sign out breast specimens, and you know that these are virtually all image-guided biopsies. So they carry their own difficulties. So I have nothing to disclose. So really, we're just going to use some clinical cases to illustrate limitations and pitfalls in breast core biopsy interpretation and discuss benefits and limitations of interdepartmental review of breast core biopsies. Dr. Ellis and the Nottingham group published this paper way back in 2004 about breast core biopsies and specifically image-guided breast core biopsy interpretation, and discussed how you have to consider what the clinical findings are, most importantly what the imaging shows, and what do you see with the microscope. And to illustrate that, we'll start with this first case. So the clinical and radiographic findings were this 64-year-old woman presented. She had a palpable left breast mass, and she also had a family history of breast cancer. And this was actually quite a small mass. It was superficial. That's why it was palpable, even though it was only 5 millimeters. So they did, as they often do when you have a mass, the radiologist did a diagnostic mammogram and ultrasound. By ultrasound, they said it was a quote-unquote dermal cyst, and they really thought it was benign. It's very rare for us to see a BI-RADS2. I mean, it's almost everything we see is a BI-RADS 4 or 5. And so they did think it was benign, but the patient was very anxious and she wanted a biopsy. And so an ultrasound-guided core biopsy was performed by the radiologist. If you send a patient to evaluate a breast mass and they can see the mass with imaging, they are going to biopsy it with an ultrasound probe, whether it's not needed or not. So even though it was probably accessible percutaneously, they did an ultrasound guided. This is an ultrasound image. Here's the lesion. I think this bright white line up here is the dermis, right? So it's kind of bumping up against the dermis. And this is what I got, we got multiple tissue cores were involved by this squamous lesion. We just got cores of adipose tissue, so there's no breast ducts, no breast acini. There's no recognizable dermis, and there's certainly no epidermis present. So we can see at low magnification these large islands of what look like very atypical squamous cells with some central keratinization, and you have these kind of infiltrating nests, and this kind of bluish stroma. Here's a higher magnification. It looks like squamous cell carcinoma. This is one of the other pieces that was involved, and I think on this side, it looks quite similar and has this it's kind of falling apart centrally. On this side, it is notable that it's quite well circumscribed. But again, it's just kind of sitting in adipose tissue. And looking at this over and over again, this is squamous cell carcinoma. What else could it be? It is squamous cell carcinoma. I'm a grown-up pathologist. I'm going to diagnose squamous cell carcinoma. So when you have squamous cell carcinoma in the breast, or you have to consider, is this coming from the breast epithelium? Is it a metaplastic carcinoma? There is a specific metaplastic carcinoma that is squamous. Or is it coming from the overlying skin? Now, this patient hadn't been yet examined by a physician except the radiologist, because the radiologist does do an examination. There was no comment of a surface skin lesion. Is it metastatic from elsewhere in the skin? Is it metastatic from another organ? So the top-line diagnosis was invasive versus metastatic squamous cell carcinoma keratinizing involving adipose tissue, with the comment that I don't really know where this is coming from, but these are the morphologic features and these are the possibilities. I remember looking at this and thinking, should I give this to DermPath? And I walked by the dermatopathologist's office. I'm like, hand him the slide. Doesn't this look like a cutaneous squame? Sure does. But we went kind of back and forth briefly and signed it out as such. So the case done, all good. As I said, prospective review with the dermatopathologist prior to signing it out. Once that report goes into EPIC, the radiologist gets that report. They have to make a decision about whether that's concordant with their findings or not. It's not necessarily the radiologist who did the biopsy. It's whatever radiologist is working that day that it's signed out. And they just have to make a general assessment. This is the American College of Radiology, their practice parameters, and they have to, quote unquote, determine concordance with pathology results. That's not really super helpful, is it? But that's what they're supposed to do, and it was deemed concordant with imaging, even though the imaging findings were of a probable benign lesion. And a few days later, we had our weekly breast radiology pathology correlation conference, which every week we look at every image-guided breast or axillary core biopsy and decide whether radiology and pathology agree. That was another pathologist and another radiologist, and it's deemed concordant. So now we've had a couple layers of review so far. And then, so the patient gets a phone call. You need to see a breast surgeon. And also they were sent to a dermatologist. And she saw the dermatologist first, which is great. Then we have now a documentation of a physical exam findings, a 7-millimeter subcutaneous nodule with a punctum, and they thought it really looked benign. And they told the patient it looks benign, and we think it can come out easily, so they did a simple punch biopsy that day in the office and removed the lesion. The patient saw the breast surgeon. A couple days later, the skin punch had not been signed out yet. The breast surgeon said, yeah, I think this is a skin lesion. We have to wait for the pathology results on the excision. So this is one cross-section of the, it's a generous punch biopsy. Here's the epidermis, dermis, here's the subcu fat. We still don't see any breast tissue in this specimen. And here's the lesion. And you can see we kind of got a hint of this in some of the cores where it has this nicely circumscribed border. It's now been distorted a bit because it's had a needle stuck through the middle of it a few times. So you have biopsy site changes as well. But when you look at it more closely, you can see like, okay, if you stuck a needle through this thing, it's gonna look like this. And it looks like an invasive squamous cell carcinoma. It looked really atypical. It had a lot of cytologic atypia on the initial core biopsy. And when they looked at the whole lesion and saw how circumscribed it was, and the atypia maybe wasn't as exciting in the resection specimen, they diagnosed it as probably a proliferating tricholemal cyst, a proliferating pilar tumor, an atypical tumor, but not a malignant tumor. In their comment, they said it's well circumscribed, it's partially cystic. The atypia, overall, we think it's reactive. and that it looks like it's completely excised and she's done, just needs clinical follow-up. But this patient is, as any patient would be, right, anxious to start with. They have a family history of breast cancer. They have a diagnosis in their chart that says they have cancer. And now they have one that says they don't. Well, the dermatopathologist did due diligence. They brought the case back to the breast service and said, okay, this is what we have. And so when they signed out their report, our report was immediately amended for the correct diagnosis. She did have a Mohs procedure done afterwards, and there was no residual tumor in the Mohs. And so, and breast surgeon agreed with the dermatology evaluation. But so in this case, what pitfall? Well, even though we knew what the imaging findings were, there was really somewhat incomplete correlation of clinical and radiologic findings with the histologic findings prior to sign out of the path report. And also, during our correlation conference when we're supposed to do just that, basically the radiologist believed us when we said it's cancer. And it's not the first time, right, that they thought a lesion was benign by imaging and it's actually malignant. But so we have these methods to try to prevent this from happening, but in this case it didn't work. Certainly we realized it could be a cutaneous lesion in the differential diagnosis. That was correct. But we should have considered skin lesions that are something less than squamous cell carcinoma. And so maybe like a more thorough conversation with the dermatopathologist, like, hey, this is really strange, like radiographically this looks completely benign. Is there anything else this could be? And so maybe we could have taken a step back and just called it atypical squamous proliferation or something. I hate, you can spend your whole life calling everything atypical. You don't want to do that, right? But in this case, I think that would have been the better way to go. Because this was a skin lesion that was sampled with a percutaneous core biopsy, it just didn't have the proper orientation. It was fragmented and made it a little bit harder to figure out what was going on. And we have a great breast radiology team. They're so good at their jobs. And like I said, they're going to biopsy it. So sometimes it's actually better if the patient gets a clinical biopsy, a percutaneous biopsy, skin punch or shave. And so in this case, the pathologist kind of fell down on the job a little bit. The radiologist believed the pathologist, and the clinicians were the ones that figured this out, right? So like I said, this patient was very anxious. She asked her primary care physician, she asked the breast surgeon, she said she wanted mastectomy. You really have to walk it back after you've made this diagnosis of cancer. And so, we've all seen the Swiss cheese model of of accident causation, where it falls through one hole and then falls through another, and if they line up right, and hopefully we can block it from falling through the third hole in this case. So our next case is a 70-year-old woman. She has a 10-year history of 10 years ago of left breast invasive carcinoma. She had a mastectomy at that time. And she had a screening and then diagnostic right mammogram, which showed a small mass in that right breast, also some associated dilated ducts. But this lesion was really not seen by ultrasound. And so for that reason, they couldn't do a ultrasound-guided biopsy of that main target, that lesion. They did, when they were looking for this thing by ultrasound, they found a different mass that was closer to the nipple, and they found an intraductal mass, and for that reason they did an ultrasound-guided biopsy of the intraductal mass. So this is the stereotactic biopsy of the 8mm mass, and we get standard 3 levels or 3 slides per block, right? They may have more than 1 level on each slide, and this specimen was really unexciting looking. Like, it had these big ducts and lots of fat, and only on level 3 did we see this. Sorry, this is a low magnification, and here's that higher, this bit of atypical ductal hyperplasia. but it's on level 3. So you have to look deeper, right? You have to look harder. And so we got some deeper levels, and this is level 8. This is a different core from that same block. Here you can see it's kind of been disrupted here, but this is a tiny little invasive carcinoma. And here we see it at higher magnification. It's just over 1 millimeter, so technically not microinvasive anymore. A low grade. We were able to do biomarkers because we had saved ribbons between the levels. And so she had this diagnosis of this tiny little invasive carcinoma. Well, maybe it's bigger, maybe it's just they got the edge of this 8 millimeter mass. We really don't know, but we have a little bit of invasive carcinoma. And then the other lesion that they found incidentally when they were looking for that one with ultrasound, this is an intraductal papilloma. It has this atypical hyperplasia, but since the cross sections of these so small, only about 1.5 millimeters, we couldn't call it DCIS. We called it atypia in a papilloma, or atypical ductal hyperplasia in a papilloma. And so now she has these 2 lesions. They're both quite small, but they're kind of far apart, and one's just behind the nipple. I don't know exactly how they could have potentially done 2 lumpectomies, but they didn't. They ended up doing mastectomy. So anyway, here's a summary. The invasive ductal carcinoma, at least 1.3 millimeters. In that core, we also saw, or in that specimen, we also saw ADH. And then the subareolar mass is intraductal papilloma with atypical ductal hyperplasia. And in the comment, that we see the biggest span of that disease is 1.5 millimeters. So just to kind of correlate what was the radiology and what's the pathology, remember, so we were able to find this tiny little invasive carcinoma only on deeper levels, level 8, and but that does seem to correlate, right? And then the intraductal mass, retroareolar, sounds like a papilloma. It is a papilloma. It has atypia in it, though, too. So as I said, she did opt for mastectomy rather than 2 lumpectomies, which would, include a central lumpectomies are sometimes disfiguring. Sometimes they have to remove the nipple. And she also had a sentinel lymph node biopsy. So in her mastectomy, she had that core biopsy site where we saw the 1.3 millimeters invasive carcinoma. There's actually less left, so it's not like it was a little piece of a bigger tumor. That was actually as big as it got. So that she stays at stage T1A. And then there was also another focus of invasion, but it was actually microinvasive. That focus had not been biopsied before. And then those 2 foci were in this background of DCIS, about 3 centimeters of DCIS. So she has extensive DCIS. And the DCIS extended to that intraductal papilloma. We had called it ADH before, but now it's enough to call DCIS. She also had some classic LCIS and some ADH. And she had 1 benign lymph node. So she had a lot of surgery for not so much disease, but she did have, her diagnoses were correct, and she got what she needed to do. So, well, how did we find this, and was it good that we found it? I think it was. So breast core biopsy processing, I was looking for there must be a universal standard, like there must be a bare minimum. Well, there isn't. In general, just like any core biopsy, you can put several in one cassette, usually 4 or 5 at most. If you read in a textbook like Schnitt and Collins' Biopsy Interpretation Series or Lester's Manual of Surgical Pathology, or even that other article from the Nottingham group, pretty much many people use 3 H&E slides per block. That's a kind of standard workup. Understand that stereotactic core biopsies for calcifications may require additional levels. These may be a larger bore needle, they may be vacuum assisted, and so you get these kind of thicker tissue cores. And so it's harder to sample that adequately to get deep enough in the block to see these very small lesions. If you have a large invasive carcinoma, you probably actually only need 1 level, but we get 3 by just our standard operating procedure. When I was a fellow, now many years ago, they would get 5 H&E slides per block. I don't think Ioana's not here. Ioana did fellowship at the same place. So they cited this study from 2001, and basically they started out in the study with 3,000 core biopsy specimens, and they ended up kind of honing in on these 95 cases that only had ADH. And these specimens had all been evaluated with 8 slides per block. And they found that, okay, for these ADH only cases, where did we see the ADH? Did we see it first in the first level, or et cetera? And they found for all of them, at least the first 5 levels. If you got 5 levels, you're gonna find the ADH. The 6, 7, 8 weren't really needed. So that's why some places like McGee routinely does 5 slides per block. I think you can make the argument, like if you know it's for calcs, you might set up a protocol to do 5 for those. But anyway, like I said, there's no standard. And in general, you just need to have a low threshold for additional levels if your routine levels are not diagnostic. This is from our Fairview West Bank protocol. And this is how they do core biopsies in general, but including breast cores. They routinely make 3 slides from the paraffin embedded tissue. The first is supposed to be about 50% of the full face, 75% for level 2, and 100% is the goal by level 3. And in between these levels, they save ribbons, right? They don't actually make unstained slides. They just crank the microtome and get 10 usable sections, and they put those flat and they store them, and we can use those for immunostains for biomarkers and for whatever we want to do immunostains. So ribbon 2 is the default, because you can imagine that's usually the most diagnostic ribbon, or the more diagnostic ribbon. But if, for instance, you only see cancer in level 1, then you're going to want to order your biomarkers on the first ribbon. Similarly, if you only see it in level 3, then you're going to want to order it on the block. But this works really well. They do a great job in the histology lab. So the third case and final case, a 70-year-old woman. She has a history of left breast invasive carcinoma. Oh, that's not right. Sorry. There we go. 60-year-old woman. She had a very small palpable mass, and she had bloody nipple discharge. And that palpable mass was visible by ultrasound, 3 millimeters. They also saw this kind of indistinct larger lesion, 3 to 4 centimeters, kind of near that palpable mass. And the radiologist described it as kind of a firm area, like they felt they could palpate something abnormal there. And then they also found a subareolar 5 millimeter mass. They thought that might be an intraductal papilloma. So they did 3 core biopsies of those 3 lesions. And this was, again, done at an outside hospital. I remember distinctly seeing this case. I thought I remembered it as being like 20 slides, but it was not. It just seemed like it. There was only 1 block per specimen, 2 H&E slides per block, and 2 levels per slide. So not onerous amount. And a benign diagnosis had been rendered for each site, and including fibrocystic change, lots of inflammation. And she was referred. The patient, again, was anxious, and before to just kind of decide how to manage these lesions and her symptoms, she was referred to a breast surgeon. And the breast surgeon, of course, went to the radiology team and looked at the images, and they just had the path report, and they're like, "Oh, it seems fine. I think we'll probably end up seeing her again in 6 months for imaging to see if anything kind of blossoms." So right now we have benign diagnoses, and they sent the slides along. And I have to say, like, of the breast consults we see, I would say less than 1% are benign. Like, they're virtually all patients who have a diagnosis of cancer coming here for some sort of treatment. Very uncommon to have a benign breast core to review as a consult. So, the one I'm going to show you is this lesion that was this kind of indistinct 3 to 4 centimeter lesion, which they detected by ultrasound near this pea-sized palpable mass. And this biopsy was just chock full of inflammation. Here's this big duct, and it's lined by benign epithelium. It's got all these inflammatory cells around it. Here's another duct and tons of inflammatory cells and all these little blood vessels with very reactive looking endothelial cells. And a lot of these cells were, inflammatory cells were plasma cells, which makes me nervous in general. And here makes me a little bit more nervous when I see this little focus of atypical lobular hyperplasia. And it's just so hard to kind of rule out a small invasive lobular carcinoma in this situation. So I wanted to prove that this is indeed ALH. And so we got the block and we did ECAD here. And I was like, let's just do cytokeratin. It's so hard to look at this these slides to figure out what's going on. So we did cytokeratin on this block too. I don't actually have those slides anymore, but this is an H&E recut that we got from that block. And you're gonna have to take my word from it. From here to here there's little infiltrating tumor cells. Here you can see a little bit higher magnification. There's also like interspersed little blood vessels. It's very hard. It was much easier on the cytokeratin immunostain to see these infiltrating tumor cells. And they were ECAD here and negative too because it's lobular carcinoma. So the diagnosis at this site was at least microinvasive lobular carcinoma, ALH, fibrocystic change, all this inflammation, et cetera. But the dominant finding in these 3 biopsy sites in the same breast was of inflammation. I think the one thing that was fairly easily seen was this ALH. Now, ALH it's an incidental finding. It's not usually a surgical finding, but maybe it just kind of gets your guard up. You have to think, what's going on in this patient who has these mass-like lesions? And so this very cellular stroma made it harder, especially these plasma cells, because of course, lobular carcinoma is often plasmacytoid. And in retrospect, like I looked at those slides multiple times, and I did not see that microinvasive carcinoma, but once I got the keratin and saw where it was on the recut slides, you could see it in retrospect on the original H&E levels. So that was, in this case, I don't recommend doing that in every case, but in this case it was helpful. She did undergo mastectomy. Here's invasive lobular carcinoma that's more clear cut. This is the same tumor, just a different part of this same one tumor. And this is a ductal component, so she had a true mixed invasive lobular, invasive ductal. It was only 12 millimeters. It wasn't a big tumor. She did have a fair amount of DCIS, extensive intraductal component. She had also LCIS, not surprisingly. Also had benign fibrocystic change and columnar cell change, and she had 2 benign senate lymph nodes, so T1C and 0. So what can we learn from this? Well, this patient had a very complex clinical picture, and she had a small palpable mass, and the initial core biopsy was benign, but at mastectomy, that biopsy site, there was DCIS. She had this larger mass-like lesion, which when biopsied had this ALH and microinvasive carcinoma, which was obscured by inflammation. And at resection, she had this 12 millimeter invasive carcinoma, DCIS and LCIS. And this she also had nipple discharge in the subareolar mass, but she never had a diagnosis of intraductal papilloma after all that. So this case from the outside institution had been reviewed by a second pathologist. And, like 9 times out of 10, I think everyone's going to miss that. Sometimes you get lucky, right? So, and sometimes you don't. Some people really advocate for prospectively reviewing every breast core. And I would argue that it's very hard to do that in a meaningful fashion. It's a very time-consuming process. So, if it's obviously malignant or clearly atypical, that's not so hard to do, right? You can usually do that looking at one slide. But if you're trying to prove something's benign, that's much harder. And so in our group, the rest of the Fairview pathologists wanted to have this policy that we would prospectively review all our breast cores. And at the time, it was Dr. Ritchell and I were the only breast pathologists. I'm like, we just can't do it. There's no functional way that we can do it. So we just, created this system where we try to review things. Anything that we have a question about, we review prospectively. And so that decreases but does not eliminate the chance of misdiagnosis. And so just in summary, sorry to go a little bit over time, for these image-guided biopsies, you have to know what they were looking for. Like, how can you know if you're finding something that explains their imaging findings if you have no idea what they're looking for? So is it a mass-like lesion? Is it calcifications? Is it either of those things with enhancement? The electronic health record is very useful in this regard. They specimen radiograph all these cases for calcifications, and you can see how big those calcifications are. We have our weekly conference. It is helpful but not foolproof, as we saw with the first case. But it does allow for a direct conversation between the pathologists and radiologists. And importantly for us, I really like it because it's a good, maybe the residents don't agree, but I think it's a good teaching opportunity for the residents to kind of get an idea of doing that correlation in real time. And the radiology residents as well. And so as far as like how are the specimens processed, there's no standard. You just have to know what they're doing in your lab and know to have a low threshold for deeper levels. And you have to work along with your clinicians and radiologists to minimize the error. You have to share challenging cases with colleagues prospectively and understand what your diagnosis means for the patient. So the patient who I diagnosed squamous cell carcinoma, she might have ended up with a mastectomy. It would not be unheard of, and that would be a shame, obviously. If you have just ADH, maybe you have ADH in 2 sites, well, the patient you may think, well, they can just do lumpectomies, but the patient may end up with a mastectomy. So it's not always just going to be a small lumpectomy. And even a small lumpectomy can be a morbid procedure. So thank you for your attention. This is my dog a couple weeks ago when I still had hope for the world. It's a little bit different now, but it was a beautiful day.
You were never late, and actually this tells you, so your talk was supposed to go to 45,
Okay.
10:45. So we have we have a few minutes, 5 minutes for questions. Any questions for Dr. Klein?
Somebody's got to have a horror story. Usually the horror stories come out. Let's hear them.
Yeah, since you asked me a question, I think I'll ask you one back. But it's more of a comment. And I think one of the things that you emphasize, which I think it keeps coming back, and I'm sure we're going to hear more of that, is the importance of understanding the implication of your pathology report on the response. So pathology report is becoming, it's always been, but I think even more than ever before, is becoming more and more critical in decision making. And our clinical colleagues, they trust us, but they always think that pathology is like a magic thing that you just put it in, you look at it, and you have all the answers. So I think just knowing what the patient is going to get the moment I push this button, I think is a very good thing that may cause us to pause and say, maybe I need to be sure again before I push the button. So I'm glad that you emphasize that as well. Thanks.
Thank you. Good point. Good point.
Yes, Asha?
Thanks for the talk, Dr. Klein. I had a question about levels and how do we, like as trainees, develop a threshold for when to order levels for our cases?
Oh, you mean when you're previewing cases on your own? I won't say there's no downside to levels, but there's almost no downside to levels. I mean, they don't cost the patient much anything, but they are work for our histotechs. So sometimes it's straightforward. Okay, this biopsy's for calcs. I don't see any calcs. Or this biopsy was for, lots of calcifications. I can see it in the specimen radiograph, and all I see is like 1 10-micron calcification. That's that kind of thing. So levels are almost always a good idea. And also for our lab, even if you order it without ribbons, like if you order levels 4 through 6 and you forget to order the ribbons, they're going to save ribbons. So you're not throwing, that tissue is not all going in the bottom of the microtome. Some of it's being saved. So yeah, good question.
Thank you so much, Dr. Klein, for this talk. I really appreciate it and brings up, I think, a lot of salient points that a lot of other previous lectures have touched on as well. And I apologize for asking you this question, but it's something that I've found myself thinking more and more with each subsequent session today. But I was wondering if you could talk a little bit about the importance of establishing a open, honest, and questioning culture with our clinical colleagues and radiological colleagues. I know some of the cases that you talked about today, what was initially maybe found on pathology or it was found on radiology didn't correlate. And I know some of the other cases brought up in some of the previous sessions today also had kind of similar discordancies that maybe were not addressed. And so I'm wondering if you can kind of just talk about how, maybe if we had some of our clinical or radiologic colleagues, if they were less likely to take what we say at face value, and especially if something doesn't fit, how that could potentially affect outcomes.
Yeah, it's a great question. I know every breast radiologist well. I know all the clinicians well. They all have my cell phone number, believe me. We talk all the time. And yet, yeah, I feel like for that squamous thing, maybe if they had just said, really? Like, Mala, are you sure? But, I think part of it, there's always that chance that something is seen radiographically. So they I guess that's a downside. Like, they worked with me for a long time and they trust me. So maybe they shouldn't trust me so much. But they definitely do call, if I'm not definitive in a report, they'll call and say, well, what do you mean by this? So, and like I said, the weekly conferences are helpful as well. But it's a great question. I don't have an absolute answer for it. But I have said, we had a patient who had this like spindle cell lesion in the breast, and it had been evaluated by an excellent pathologist or group of pathologists here in the metro area. And they kept saying, oh, we need to have the path reviewed. We need to have the path reviewed. And I was, yeah, okay, well, I'll be happy to review it. But, the chance of me coming up with something new compared to, they've done this massive workup. Sometimes they have too much confidence in you. So it's interesting. There's upsides and downsides, I guess.
Yeah, thank you. That was really a great talk.
Oh, thanks.
I did want to just address that question. I'm Susie Densis. I'm from University of Washington in Seattle. Hi. And, different cultures in different places, but I have practiced. I'm a breast pathologist, so I appreciate all your difficult cases. I've practiced in different private settings, in different university settings, in different states. It's my gray hair. And I have never had a clinician yell at me for calling them to discuss cases. They're usually very grateful for the contact. And one approach that we take is, if it's a little weird, we pick up the phone and just be honest and say, this is really weird. Can you tell me what's going on here? Sometimes they even go as far to say, how would you like me to report this out? And we have that conversation just because we don't know what their relationship with the patient is. And so often, as pointed out really clearly by your great lecture, we don't know what the consequence is going to be until we've talked to them. So it's a team sport, I think, and that's one approach.
Thank you. Good point. Thank you.
Any other questions? All right, so I think we are ready for, thank you very much, Dr. Klein.